Hi, everyone. My name is Meg Bruner, and I'm sitting in today as your webinar series host for Dr. Via Carlini, who's out of town. And we're going to get started. Let's see here, slides. Today's presenter is Dr. Steve Woolworth. He's the Vice President of Treatment and Reentry Services at Pioneer Human Services, which is one of the nation's largest social enterprise organizations. And he's going to be talking today about best practices in recovery-oriented systems of care. All right.
Okay, good afternoon, everyone. I want to thank the Northwest Addiction Technology Transfer Center Network and the University of Washington Alcohol and Drug Abuse Institute for inviting me to give this webinar. I'm going to talk for about 30 minutes, give or take, and then there'll be some opportunity and time for questions. The presentation I'm going to give today, Best Practices in Recovery-Oriented Systems of Care, the case of Pioneer Human Services in Washington State, will be a little bit of storytelling and a little bit of kind of walking through the history of Pioneer, which has been around for 55 years. And because best practices change over time and recovery-oriented systems of care have changed over time. And so I like a historical perspective because I think to understand where we are in our moment and where we are going requires a deep understanding and appreciation for where we've been and the context of where we've been and some of what we're carrying forward with us. And so with that, I will spend a few minutes talking about who Pioneer is as an organization, how it operates, what makes it a social enterprise. And then I'm going to take us back in time to the founding of the organization and the initial envisioning of a recovery-oriented system of care. From there, talk about how Pioneer grew and developed alongside some of the social policy developments at the time into a multi-service organization. And then really kind of leapfrog forward a little bit to 50 years in terms of the scaling of the system of care. And then spend some time looking forward at where are we moving with recovery-oriented systems of care and what are some of the key elements of those. And we'll conclude by highlighting an example of some work we're doing here in Washington State or just beginning to undertake right now in terms of driving some innovations around recovery and building some integrated continuums of supports and services, especially around those who are impacted with opiate use disorder. And I will talk a little bit about that as an example as part of the larger theme of this talk. And so with that, let me go ahead and get started. Pioneer Human Services. Pioneer was founded in 1963. We are a 501c3. Our mission is focused on providing individuals with criminal histories the opportunity to lead healthy, productive lives. And we are, as Meg noted in our introduction, a social enterprise organization. And what that term really refers to are organizations that have a model that marry social impact with financial sustainability. So in the case of Pioneer, we have integrated a multi-social service platform with business and commercial ventures to achieve social impact and financial sustainability. I'll talk a little bit more about what that looks like here in a few slides. Pioneer is headquartered out of Seattle, but we operate currently in over 50 locations across the state. We have been serving approximately 10,000 individuals per year, and that's been holding pretty steady for, I think, about 5 or 6 years now. And employees, we have about 1,000 folks who work for Pioneer. Have annual revenue in excess of about $80 million to fund all of this. So the continuum of supports that Pioneer offers, the multi-services, we really serve individuals across an array of different service types and models, and I've listed some here. I won't read through every line, but you can see we do, because we're focused on serving folks in the criminal justice system, we do have a in-reach with some behavioral health treatment. We operate in a number of county jails where we're doing both substance use disorder and mental health assessment and treatment in some county jails. We also have long operated residential reentry centers for the Federal Bureau of Prisons, an array of other types of community residential centers that range from harm reduction, detox, and sobering, all the way through to residential treatment, in addition to outpatient behavioral health clinics. We have a diverse portfolio of youth and young adult programs focused primarily on residential care, but also some in-home parental counseling and parental skill building supports as well. And we have some job readiness, pre-apprenticeship programs, community service programs, and we have a wide array of transitional and what we're increasingly calling service-enriched housing, and also some permanent low-income housing in Spokane, Seattle, and Tacoma, and in the North Sound as well. So we are diverse in the kinds of services we offer, and I'm going to talk a little bit about how we came to be this way in a few slides. But if you look at the map of Washington here on slide 8, you can see where our service intensity is across the state. We operate primarily in 4 regions in Washington state. That's Spokane, for those of you who don't live in Washington state. That's at the eastern part there. And then up north in the North Sound, in King County, and then in Pierce, which is the county below King there. Those are the main population centers in the state of Washington. So Pioneer Enterprises is the arm of Pioneer that the business and commercial ventures. It includes several of them. First and foremost is Pioneer Industries, which currently entails 3 manufacturing plants totaling over 110,000 square feet, where we primarily make products for the aerospace and other commercial industries, like culinary and construction equipment. In these plants, the work and the functionality ranges everything from sheet metal fabrication to machining, water jet, finishing assembly services, screen printing. We make parts for every Boeing commercial airliner and upwards of 1.7, 1.8 million airplane parts a year, both those that go inside the airplanes and outside the airplanes. We also make equipment for kitchens, commercial kitchens, and construction equipment. And we have grown these enterprises over our 5 decades plus of existence. And it's a wonderful opportunity for many of the clients who come through our programs to develop skills. And currently, about 65% of our manufacturing workforce are folks who have transitioned out of prison through our programs or may have been struggling with lifelong addictions. This also helps provide self-sustaining revenue to the organization. And it also, I think most importantly on the social level, contributes to stigma reduction, because many folks may harbor discriminatory views of folks with criminal records or folks who have been battling substance use, and to see them not only engage in clean and sober living, but being a part of complex workforce like aerospace manufacturing that requires significant skills in operating machines really helps reduce stigma and I think changes people's views of human potential. Pioneer Enterprises also entails food services. We have an institutional kitchen that provides many meals to many of our programs and then also to other customers in the community. We have a distribution center as well, where we ship airplane parts as part of Boeing. And over time, we have had many enterprises kind of come and go, which happens with business cycles. They've included restaurants, publishing company or printing company rather, construction, bed bug detection services, and so on. They kind of come and go. But Pioneer Industries has been the staple of who we are as a enterprise, and there are very few social enterprises, I think, in the United States, much less the world, that have what we have at scale in terms of the complexity and size of the operation. We're very proud of it. So Pioneer works. In the case here, you see of Abram. This gives you one example. We have many paths that people may experience through our services and its connection to enterprise. In the case of this gentleman here, he came out of federal prison and came through one of our residential reentry centers. It was admitted into a pre-employment training program, about 10 weeks, or no, about 4 weeks, and then into about a 10-week pre-apprenticeship program in manufacturing, which led to employment on the plant floor, and he's currently getting a certification as a apprentice right now. And so that gives you one example of a pathway here. In the case of Michele, she came to Pioneer through a drug offender sentencing alternative program through the Department of Corrections, came into Pioneer via a job training program, actually ended up living with us in one of our transitional housing units, was able to then secure a job on the plant floor, was able to move into one of our permanent housing locations, and then took a job with our, at the time, our pet detection business, and has since now moved on to buy our own home and is also gainfully employed outside of Pioneer. So Pioneer was instrumental in helping her get some traction, get her footing, and then kind of relaunching and reintegrating back into society. So that gives you a little sense of our profile as an organization, how we operate. We are large, we are geographically dispersed, and we are complex. And people may experience Pioneer differently depending what door you come into the organization. And so how did this all get started? Well, let's talk a little bit about how the initial recovery-oriented system of care, those were not the language or the words that were used at the time of Pioneer's founding, but I actually think it's an appropriate frame for which to revisit our origins. Pioneer was founded by Jack Dalton, who grew up in Seattle, was a lawyer from a prominent Catholic family here in the city. Jack actually ran for Congress at one point, didn't win election, but was well known in Seattle. Jack struggled mightily with alcoholism, and was part of the reason why he was sent to prison in 1968 for embezzling from some of the trust funds that he was managing. When Jack was sent out to Walla Walla Penitentiary and walking along the big yard, which you can see there in the middle picture, he listened and learned that many of the other men were also struggling with alcohol and drugs. And as part of his experience in the prison, he was connected with an AA group of individuals and men who drove over to Walla Walla from Seattle, who engaged in fellowship with other inmates who were committing to sobriety and recovery through the 12-step process. And Jack actually started his own AA group at Walla Walla. When he was released and returned to Seattle, he was determined to do something to help everyone who was transitioning out. So he leveraged his network, which included some of the individuals who he embezzled funds from, and was able to scrape together support to open up what you see there as Pioneer Fellowship House. And so that began the beginning of Pioneer, which started as a single halfway house in Seattle in 1963. It opened late that year with 17 men who paid about $25 a week to stay there. Their residency was contingent upon them looking for work. Sobriety was required to maintain residence there, and there was a deep and close connection to the 12-step community as part of the practice for the community that was forming. So once the housing got off the ground and kind of got stabilized with AA supports, the need for employment services became quickly apparent to Jack Dalton, because even then, many businesses wouldn't hire people with criminal records. So Jack conceived of Pioneer Industries as a way to provide job opportunities for Pioneer clients. And there is a visionary document that he authored that is actually on the wall of our Plant 1, in which Jack envisions the potential of a sheltered workshop. And he applied. He knew somebody who knew somebody at Boeing, and Boeing accepted Pioneer Industries into their at that time what they called their philanthropic workshop program in 1966. Today it's called the CMP, or Community Manufacturing Partnership, which is an amount of work. I think it's probably 5–10% of that work that Boeing contracts out specifically to mission-driven organizations who are members of the Community Manufacturing Partnership. And Pioneer has been a part of that since 1966, so 52 years. Pioneer currently also in enterprises does compete commercially for work out there as well, but a part of our work has always been connected to CMP. So by the late 1960s, I would say the first iteration of Pioneer's recovery-oriented system was thus envisioned and actualized, and it had three pillars, focused on housing, employment, and at the time, AA fellowship. Okay, and so that really became the initial cornerstones to the organization and to the organization's social practice and value proposition to the community and for those transitioning out of prison back into our community. If you think about Jack Dalton's vision and you chart it historically on the front end of mass incarceration, which I've done here in this slide, and you can see those three trend lines are mapping the growth in federal prison, county jail, and state prison populations. You can see beginning in the early 1970s, you start to see the skyrocketing increase to where we went from roughly 100 people per 100,000, which was the rate of incarceration, to upwards of 750 per 100,000, is a significant increase. And he was really, this vision was really ahead of where we would go. And I think historians will look back on the latter 25 years, latter half of the 20th century, and most will, I think, have to acknowledge that mass incarceration was quite possibly the most significant event in the second half, the last quarter of the 21st century American society, to where 1 in 100 Americans by 2007 were incarcerated, which is pretty significant shift, and you can see it there in those trend lines. And so this vision for Pioneer, the cornerstones for a recovery-oriented system of care, were truly ahead of its time. But a lot was happening in the 1960s at that time that would really drive the growth of the nonprofit service sector, really beginning in the 1970s. And as the government became increasingly interventionist in its funding of social programs. And so in 1962, under President Kennedy, there was a very significant conference on drug abuse that contributed to kind of moving away from the punitive and law order approach that substance use is a disease. It is not necessarily a reflection of people's moral failings, which was a dominant view at that time. And the notion, I think, as many of you know, of addiction as a disease is long held. I mean, Dr. Benjamin Rush, who was one of the signers of the Declaration of Independence back in the 1700s, was quite active and prolific in maintaining that alcoholism was a disease at that time. In 1963, the Community Mental Health Act. In 1965, the creation of Medicaid and Medicare. Housing and Urban Development Act, which really expanded the funding of federal housing programs, all the way to 1967 with the President's Commission on Law Enforcement Assistance and Administration of Justice, which really began the funding of prison halfway houses. So you see, we turn a significant corner in social and public policy in the 1960s, which would have significant implications for the growth and evolution of Pioneer. And so at that point, Pioneer is in a few locations in the 1960s. This would quickly change under the leadership of Norm Chamberlain, a prominent Seattle community leader who led the organization for 15 years. And it was really under Norm's leadership where Pioneer, which had been privately funded in the 1960s, moves to align to that government funding that I had just highlighted on the previous slide. And you start to see this growth through service specialization. So the opening of work releases. Pioneer was the first to open up work release in Washington State after the law was passed in 1967. In fact, Norm opened up the first one in his home. And that moved into other halfway houses. The residential treatment in the 1970s, job training and employment programs in the 1970s, in the early 1980s, the first juvenile justice programs, and then on to a portfolio of clean and sober housing. So for the next few decades, what you really see at Pioneer is a Seattle-based model where you see folks coming out of prison being able to go into Pioneer work release or straight into Pioneer housing. You have folks coming out of Pioneer drug and alcohol treatment being able to access housing, and folks through housing and work release being able to also access Pioneer enterprises, which at that time included food buying services. There were some construction and food services then as well. So you start to still see the core cornerstones of housing, employment, and treatment, but you start to see the model become slightly more complex, slightly more mature, and begins to expand. But at that time, is still Seattle-based. However, beginning in the 1990s and then into the early 2000s through a number of merger and acquisitions, Pioneer really scales a number of these service lines. And so I'm going to kind of accelerate and jump forward to 2013, where at that point in 50 years, you've gone from 17 men in a single building to more than 10,000 men, women, and youth over the course of a calendar year in over 60 locations. 1,100 residential program beds. That's not housing, that's residential treatment, residential reentry, work release, crisis, detox, a number of job readiness and training programs, over 750 housing units, single occupancy, family housing, and then also outpatient behavioral health clinics. And so you get this significant scaling along these service lines for the organization. And the context behind that growth of Pioneer, if you look nationally at what was happening, as I already showed on the incarceration slide, you can see the state and federal prisoners there on the left. You can look at the rise in unintentional drug overdoses during the same time period. You can see the increase in assistance for housing. So if you look at the areas where Pioneer was operating, treatment, employment, housing, prison reentry, what's happening in American society at that time is significant increases in those arenas of need and demand for services as government continues to invest in those institutions. So a little bit on the context and complexities of growth. So as we talked about, so there's a lot of legislation passed in the 1960s that continued. So government begins to fund services and begins to contract these services out to the nonprofit sector at historical levels, but it cuts across institutional systems. So in criminal justice, the funding is coming across courts and correctional system, mental health system, alcohol and substance abuse, the growth of the homeless and emergency shelter care system in the 1980s, juvenile justice and child welfare systems, all with the hope of addressing social problems connected to crime and recidivism, addiction and mental illness, homelessness, family crises, out-of-home placements. And so if you just look at Pioneer's rehabilitative services and where that contract funding was coming from, we would be contracted with 6 different federal agencies: Department of Justice, Health and Human Services, Labor, Housing and Urban Development, Veterans Affairs, Administrative Office of the Courts. Within Washington State, contracts were flowing out of Department of Corrections, out of DSHS, but within DSHS, multiple divisions, right? Department of Behavioral Health Rehabilitation, Children's Administration, Juvenile Rehabilitation Administration, and then county governments, the Departments of Human and Community Services, the specialty courts, Departments of Adult and Juvenile Detention, and then also the regional support networks, which was funded through for mental health for a number of years as the sort of platform, managed care platform for mental health in Washington State. So this huge entanglement of layers of government funding creates complexity around growth internally for any organization. And so that has implications for the shifting system of care at Pioneer, which in the 1960s was local, was privately funded, And the services were highly undifferentiated. You had housing, you had employment, you had AA, and you had, I would say, a social entrepreneurship model around the organization. By the 2000s, it's become geographically dispersed, publicly funded, also privately funded still through Boeing and other commercial customers on the enterprise side, but the service side became publicly funded entirely, pretty much. The services are highly differentiated, and by all the different governmental agencies, what their intended purpose was and outcome of funding a community provider. And in addition to the social entrepreneurship model, it now becomes increasingly professional around the kind of work that we're doing in social services, as social services professionalized deeply in the latter half of the 20th century. So you get differentiated program services through categorical funding. And so all of these range of services that Pioneer was offering, it's a long way from a single halfway house for 17 men who needed employment and a close connection to AA to now a lot of real specific statements of work, as you can see here. But it's even more complex than that, because when you want to look inside any of these programs, there is a host of social change, rehabilitative services, and what I would call micro technologies of differentiated services at work. And so this is what you get. All of these practices were in place at Pioneer and continue to be in many instances as they are at other provider organizations. And so as we move into 21st century recovery-oriented systems of care, we have to become very thoughtful about getting this bull back in the barn, because really in the 1990s and the explosion of meta-analyses around evidence-based practices and return on investments from a policy standpoint of the types of programs and protocols and change curriculums that were being developed and implemented, there was really a plethora of different program designs that have taken root. Many are still with us today. And we need to get, I think, as a field, a little more focused. And it's, you know, I think, you know, my experience has led me to believe it's not what you do, it's how well you do it. And it's the commitment to doing something well and building in the organizational discipline to being able to follow through with some of these care protocols. Filter on top of that, some of the challenges in the late 20th, early 21st century system oversight. A lot of the work that got contracted out to Pioneer and other providers are compliance-driven contracts. So our regulators and our auditors come in and they, quite frankly, may be more concerned about the temperature of the water coming out of the sink than they are about the actual outcomes of the program or the quality of the clinical work being delivered or the thoughtful and rigor of the case management. There may be more focus on the 3 crumbs under the toaster oven than they are about the sense of engagement and motivation of those who are participating in the service. There is and continues to be, to a certain extent, a real emphasis on service volume, largely over service quality. And then there are also limited or fragmented scopes of work that all providers are kind of pivoting and navigating around. And so in Washington State, that meant that if you were running and still are running residential substance use disorder programs, you may not be able to treat the mental health disorders that often are accompanying them, because we've bifurcated those as 2 different systems of care. We're currently integrating them now, but we're not all the way there. And so that creates shortcomings in a recovery system. And when you cannot commit to or deliver upon whole person care because of the nature of those fragmented scopes of work, because of the way credentialing and clinical licensure has been bifurcated, And then, of course, we're all suffering from multiple data systems. And so as, Pioneer as just a single organization contracting at multiple levels of government and then multiple departments of government at each level, you can imagine the many, many, many data systems in which information is being inputted into, many of which, in which instances, are not interoperable, are not talking to one another. It's hard to get a clear view. And we're still working through a lot of that right now as a field and as systems of care. And then also legacy real estate. A lot of buildings that were able to be permitted nationally, not just in Washington or just for Pioneer, to do the work of residential care or community care may not, certainly don't have a lot of what we know now is required for the settings in terms of these trauma-informed care, in terms of the natural light, the size of the buildings, things like ceiling height, square footage, location in certain neighborhoods. All of those things have created some challenges for those of us who operate on the community provider side. So this leads me up to toward a 21st century recovery-oriented system of care. I'm going to kind of walk through a few key elements and then highlight some work we are currently piloting right now as an example of some of that. I got about 10 minutes left to go for those of you who are monitoring our time. And then we'll have some time for questions. So currently, Pioneer's evolving program service architecture is really kind of grouped in these areas. We remain as an in-custody behavioral treatment provider. We have a growing portfolio in crisis and diversion work, really harm reduction work, meeting people where they're at, helping get people to the front end of recovery-oriented systems. We continue to be a residential treatment provider, both substance use disorder treatment and co-occurring treatment, and we were the first to the state for co-occurring treatment. We continue to have a footprint in residential reentry, although no longer in work release. We continue to be a diverse housing provider of transitional service enriched and low-income permanent housing. We have a footprint in 3 of the 4 regions we operate in with outpatient behavioral health services focused on substance use disorder, mental health treatment. We have King County's 3rd PAC team. We have a drug court contract as well. In youth and young adult, we have a range of services ranging from diversion to reentry, but also behavioral rehabilitation services and emergent placement services for kids who are in state care. And we are working with parents, many of whom, the majority of whom have been incarcerated and are trying to get their kids back. And then on our community services side, we are getting ready to open up our first community resource center. We continue to engage in job readiness for employment, some community case management services. So if you were to chart this on a continuum from restrictive settings in jails and incarcerated environments, all the way forward to employment introduction to the workforce, our service lines are distributed across a range of needs and through a range of arenas. And so the landscape is shifting, and I think we all know there is significant energy right now around criminal justice reform. We are seeing also a connection of criminal justice reform to population health reform. And we are seeing more energy around a public health lens or a public health approach to what historically have been criminal justice problems. Seattle and King County here have been a test case. The LEAD program gets a lot of national attention as an example of that, to where we're pulling back on what historically had been a law and order punitive approach and finding different ways to address problem behavior in our communities. And so we are seeing more effort from diversion services on front-end reform. There is talk nationally in states around revisiting sentencing reform, but we are seeing a lot of innovations around detox and sobering and specialty courts, and just a plethora of specialty courts. The first one opened up in 1989. We've now got, I think, upwards of over 1,300 specialty courts that divert people from incarceration into other opportunities. So On the reentry side, we have gotten, I think, a lot smarter around the science of risk-need responsivity in terms of programming in residential reentry, working on becoming more responsive with service delivery. On the population health reform side, there is increasing attention to social determinants of health. And I think we understand that healthcare really, and the quality of healthcare has a relatively small impact on the health of populations, that we really need to look at education and housing and leisure and recreation and how the social organization of our communities and the physical and environmental organization of our cities. There is a significant move towards whole person care, and here in Washington State on the integration of behavioral health and primary care, and that other states are ahead of us on that. We are seeing increasing concern about the fabric of our supportive and affordable housing capacity in cities across the country. Seattle is somewhat ground zero for that right now. The pressure on our coordinated entry system and rapid rehousing for homeless populations, many of who we know have a incarceration history, who are also impacted by many of the comorbidities that we're seeing on the population health side. And we're also seeing unique new partnerships coming together on the private nonprofit workforce side. Pioneer and Boeing is a long-standing partnership. Amazon and Fair Start here in King County is another one, and there are others across the country where we're seeing unique, new, innovative pathways to help folks who are system impacted or coming from deeply impoverished backgrounds access social benefits and opportunities. And so the landscape is shifting significantly, and there are implications for recovery-oriented systems of care. We know, for example, some of the key elements that our services need to be integrated, that there's a reason why many hospital health systems are buying up housing across the country to keep people out of emergency rooms. And so we're starting to see the health and housing nexus in that intersection. We know through models like supported employment, that employment can be a significant piece of somebody's recovery. Okay. We need to think about recovery-oriented systems as multiple service continuums, diversion service continuums, treatment service continuums, reentry service continuums. We need lots of innovation and design around, levels of care. When the American Society for Addiction Medicine came out with this notion of levels of care in the 1990s, I think we're still working in many communities to put together the architecture that allow systems and individuals who are impacted by those systems to move to the appropriate level of care in a seamless and continuous fashion. We need levels of service and care that are based on risk, need, and strengths. And by risk, I mean, in the case of Pioneer, both criminogenic risk and clinical risk. We need our services to be assessment driven, and that's, I think, across the board. We have so many folks who have been impacted by these challenges. We should be thinking about recovery-oriented systems of care having cadres of peer support, peer coaching, peer navigation, care coordination, community health worker models, where we're utilizing the wisdom and the lived experiences of those who have been impacted by the system to help others who are still on the front end and still struggling. And we need models of care that really address a whole person and are responsive to culture and ethnicity and age and sex and gender and a whole host of other kind of demographic criteria that can impact a quality of a person's experience in a care setting. And we have more than enough research and knowledge to know that we need to begin with the universal assumption of trauma, that folks who are impacted through addiction and substance abuse and incarceration, let's just assume everyone's coming from a standpoint of trauma, and there are significant implications for how we design our care environments with that knowledge in mind. A few additional key elements. We need contracts and statements of work that shift service delivery away from volume towards outcomes and value. We are seeing that happen with a number of the Medicaid waivers across the country right now and here in Washington State. But we need contracts for providers that are funded at high enough levels to pay for quality assurance activities and staff development that allow us to do outcomes tracking and fidelity requirements, so that whatever we do, we know we're doing it well. And we need integrated data systems. Okay, so lastly, I've got about 3 or 4 minutes left just at a high level to talk a little bit about our diversion services continuum of care as an example of how Pioneer is trying to still be pioneering and moving into and developing the architecture around 21st century recovery-oriented system of care. And in this case, it's around opiate use disorder. So in the North Sound of Washington, the data which I have pulled here from the University of Washington Alcohol and Drug Abuse Institute website, which is a fantastic data repository for those of us out there in the community that are trying to understand conditions and trends over time. You can see 4 of the 5 counties up north. You can look at in 2 different measurement periods the significant increase we're seeing in opiate drug-caused deaths involving opiates, and then crime log cases involving opiates. You see significant increases. So the trend lines are mostly moving in the wrong direction dramatically. So one example of a diversion center program that we hope to be opening any day, literally any day, a 44-bed diversion center program in Everett. It's in partnership with Snohomish County and their Office of Neighborhoods, where social workers are embedded with law enforcement and who are going out into the homeless encampments, the tent encampments, where folks are struggling mightily with opiate use disorder. Those who are motivated and amenable to treatment may, and many of them are, and right now there's nowhere for them to go, will be allowed to come into the diversion center. It's a short-term program. It's really designed to divert these folks from incarceration and contact with the criminal justice center in the county jail. So they will be referred through the Office of Neighborhoods to the program. We will be offering medication-assisted treatment through our partner Ideal Options on site with buprenorphine induction. And the purpose was we're envisioning folks will stay for about 2 weeks, and the time there is to have some short-term stabilization and then to focus on possible residential treatment, admission to detox, or working with a coordinated entry system for a housing placement with some intensive outpatient treatment. Those are the initial goals. Is low barrier. We're meeting folks where they're at, and we're really on the front end of helping folks kind of walk themselves into a system of care to get help. So it's we'll be running 24-hour program. It's residential. We'll be transporting folks to their appointments and to their referrals. There'll be some on-site case management. We have an EMT model where our shift leads will be EMTs. All of our staff were trained in principles and practices of recovery, around motivational interviewing, mental health first aid. And the outcomes that are being measured and looked at by the state of Washington are around recidivism and desistance, that's bookings and days spent in jail at 6 and 12-month intervals, service engagement within the public behavioral health system, and housing stability at 6 to 12 months. So for those folks who come into the program, what are their outcomes in those areas 6 to 12 months out? This is a pilot program, and how well we do will be aligned next to those outcome criteria. So we're also opening up a community resource center that will be right across the street from this diversion center, as you can see there in the picture. And the community resource center will be a place where folks can get their IDs and licenses, they can get assessments and referrals, can access coordinated entry housing. And so you can start to see a bit, and folks who are in the diversion center will be able to walk across the street and utilize many of the service providers and partners who will be at the resource center, kind of a one-stop shop model there, as an example of how we're starting to integrate some different services here on a continuum. The last piece of which is a 25-bed pilot program that we're also going to be opening in the region, residential, on July 1st, that will offer medication-assisted treatment, induction, and maintenance for methadone, Suboxone, and Vivitrol, a partnership with the Swinomish, the tribal nation, in their Digwallic Wellness Center for daily methadone dosing. We'll also be able to host Vivitrol and Suboxone dosing as well. We'll have treatment programming focusing not just on the sort of traditional relapse prevention and CBT, but also on chronic pain management, the grief and loss, trauma. We'll have some programming around parenting, in addition to community engagement work around peer support and community care coordination. And so that is accompanying individuals back into the communities, understanding and meeting their prescribers, figuring out where they need to go for their appointments, to help really with thorough discharge planning. There will be Narcan kits that are distributed at discharge. So you can see a little of an example here of how a continuum of care is coming together, that is integrated, that is community-based. We also are opening up a 10-bed transitional housing program as well in Everett, not far from where the diversion center will be. So go back to 1960s, treatment, housing, and employment. Here you can see where that frame is being reapplied with 21st century knowledge, research, and practices. You can see the housing, you can see the treatment, and as folks come through on the back end, the opportunity for some employment supports as they discharge from our OUD program. So thank you, folks. That is the conclusion. I went a little longer than I wanted to, but we still have about 15 minutes left for some questions, which I see the first one has come in. So question, this is kind of fun. It's like doing a radio show, host share. So what about child support issue, how to resolve that? So what about the child support issue, how to resolve that? So there are, in a number of our residential programs, we do have case managers who will work with our residents around child support issues. For many folks coming out of prison or who are involved in the criminal justice system, that's what we call an LFO, acronym, police, and that is a legal financial obligation. And so that is very commonly experienced challenge for many folks who are coming out with significant restitution or child support payments and haven't had the opportunity to be in the workforce for some time. And so there are some legal associations that do volunteer work that we have partnered with at various times that have helped our residents navigate that. We do have staff in our programs that can help with some of that. And in our parental and adolescent counseling program, in our in-home work, we work very intensively with parents around that, but that is a systemic need. So I appreciate it being called out. That is an area where I think as a system, we need to continually build awareness and create better ease of opportunity for folks. I come from the place where I believe most folks really want to be the best parents that they can be. And we need to help them work through some of the institutional barriers that may keep them from being able to be in their child's lives, especially when they are ready to return to that role. The next question, do you have a printout of today's presentation? If so, where do I go to print it out?
I can answer that one. So we'll be sending everyone who registered an email later today that has the video and the slides, and it'll also be posted on our website this afternoon at some point.
Okay, next question. Does Pioneer play a role in lobbying or championing for drug law reformation in Washington State? For example, the decriminalization of small amounts of all narcotics in Snohomish County. Do you see this becoming a trend throughout the region, and do you know of any examples showing successes or failures based on similar drug law models? So Pioneer is, from our strategic plan, we have a significant emphasis on advocating for sound public policy that supports criminally justice-involved individuals around barrier removal, around basic human rights issues, around the reform of services and programs that can be more impactful. Our chief executive, Karen Lee, sits on the Washington State Reentry Council and has been a strong voice there. And so we have not, as I do not believe, have not taken a stance on some drug law reformation in Snohomish County or in Washington State per se. I'm not sure exactly specifically what the question is pertaining to there. decriminalization of small amounts of narcotics in Snohomish County. So we typically have not been involved in the county level piece as much, especially up north, a little more so in King and maybe Spokane, not as much up north. We are getting to know Snohomish County largely through some of the work I just highlighted. And so we would need to learn a little bit more about that. I'm not trying to be evasive. I don't have a strong answer. I wish I did on that. So we need to learn a little bit more about what's happening there. So.
Any other questions? Go ahead and type them in the chat box.
So for members of the recovery community who may be interested in contributing, how might you suggest they explore what type of roles and options exist? So for members of the recovery community who may be interested, well, Pioneer's website has a section called Careers of Pioneer, and there may be opportunities there to begin. We oftentimes will have jobs for peers or peer support specialists or housing case managers, where we are actually intentionally looking for members of the recovery community. We may also have opportunities for volunteering in some of our communities as from just a sponsorship or a volunteer standpoint. There may be opportunities to bring an AA meeting into one of our facilities, be it housing or be it outpatient clinics. And so probably navigating and moving through our website is a great place to start. You can also contact me directly and I can get them to the person they need to talk to as well.
Well, I have a question since we don't see any others there. So if, let's say someone is in prison and they're about to get out and they're interested in getting involved with Pioneer, what is the process for someone who wants to be a part of Pioneer? Do they usually get a referral or do they apply in some way? Or?
So for those folks who are coming out of federal prison, they, upon incarceration, need to, when they come in, they usually are given the opportunity to designate where they want to release to. And so if they are returning home to Washington State and want to release to one of those areas, about 75 to 80% of those folks who are incarcerated at the federal level will come to a reentry center. And so they will probably come to us because we're the sole provider of that service in the state. We are no longer in contract with the Washington State Department of Corrections. At one point, we had 588 work release beds across 10 halfway houses throughout the state. We are no longer providing that service, but those would, again, be referred out of the prison. There are opportunities. We have a small presence at the Monroe Reformatory to connect with us there. And through some of our community job readiness programs, there are opportunities through work release to talk to their CCO or community corrections officer, probation officer about applying for some of our programs, and you come at it that way, as well as applying through our housing as well, because we do recognize DOC has housing vouchers, and we do recognize those vouchers in our housing programs. So you mentioned Pioneer's role in fighting stigma. Are there specific actions you'd recommend organizations do to fight stigma about people with addictions? Yeah, that's a big question. There are specific actions for sure. I think, like with all issues around stigma, proximity and social geography, social proximity is one of the biggest reducers of stigma once we know someone. And, we all know someone. Even if you don't think you do, you do. Trust me. And so I think it's in that personalizing of it where I think those of us who may be struggling to find your empathy or compassion, I think learn to find your compassion when it impacts a loved one. I think at its most base level, challenging conversations that are stigmatizing or discriminatory is just really important in all areas, at all times, with all people. I think we have to start with that most basic posture, is to question comments or statements that we hear that may be implying a stigmatizing or discriminatory intent, to ensure that that is what was being intended, and then to help provide whatever knowledge or experience you have to help broaden that person's worldview. I know that sounds a little Pollyannish and Disney, but that is kind of where we have to start. I think there are much more tactical and strategic mechanisms that organizations, from marketing campaigns to advocacy campaigns, can undertake to help with public education around that issue.
Any other questions from anybody? Oh, there we go.
Is PHS still providing bedbug treatment programs, and does it serve Pierce County? We actually never provided bedbug treatment. We provided bedbug detection, where we had dogs go in and we could tell you if they were there or not. We no longer provide that service. Does PHS have a bedbug treatment and prevention packet to share with other agencies? We do not. We do not. There are, I know, a couple of other real core, I want to say Sprague might be one of them, that name comes to mind, that do bedbug detection treatment. So a few issues with sign-in. Also, use phone services. Really inspired event. Thank you for your work, holistic efforts. Oh, thank you for the comments.
Any last questions before we end the session today?
All right, well, thank you everyone for joining us.
Yeah, thank you. That was really interesting. Thank you so much, Dr. Woolworth. So just a reminder that we will be sending an email out later today that'll have the video and the slides, and also you'll be getting a link to a survey that we hope you'll fill out so that we can improve our programming as we go. And next month, we'll see you again to see Dennis Donovan talking about healing of the Continuum. All right, thanks everyone.